Um, all right, I'll start. Hi, everyone. Hope everyone's doing well. Welcome to part 2 of the Women's Health and Fertility series. For those of us who weren't here last week, I want to reintroduce myself. My name is Sonali. I'm a bio major at Stony Brook, and my friend Shina and I, who's also a bio major, with the help of Donna and Dr. Lisa from the Diocese of Rockville Center, have created this 3-part series with Jamie Hutchinson. Jamie is a fertility care coordinator and a restorative reproductive medicine nurse at the Gianna Center for Women's Health and Fertility. She promotes fertility awareness methods like the Creighton model for family planning and educates women about their fertility. Today, she will be sharing with us about weight gain, PMS, fatigue, migraines, and so much more in women and what that means. I hope you find this natural approach to women's health and fertility useful. And during this talk, I encourage you to keep your cameras off if you want to, and also keep your mics muted. And at the end, around 7:20ish, we'll have like a Q&A section. You could raise your hand or you could leave your questions in the chat. And you could private message Jamie if you feel more comfortable. Thank you for listening to me, and I'll pass it on to Jamie now.
Thank you, Sonali, and thank you, Shina, for inviting me. We are in part 2 of a 3-part series on women's health. So last week, we reviewed what are normal parameters of a woman's cycle and what is not normal. This week, we're going to talk more about what's called restorative reproductive medicine. And so I've titled it a restorative approach. When things go wrong, when you're in that category of an abnormal cycle, we want to know how to correct it. What is the most healthy way to correct it? What's the most restorative way to correct it? So this is part of a series offered through the Gianna Center for Women at Catholic Health. NAPRO technology is one of the services that we offer at the Gianna Center for Women. There are 3 locations within Catholic Health Services, and NAPRO technology, or natural procreative technology, is one type of restorative reproductive medicine. And we're really excited to be able to offer that and share that with Long Island. So just a disclaimer that this presentation is for informational purposes only and is not intended to be a substitute for actual medical or mental health advice from a doctor, psychologist, or other medical health professional. This presentation will provide an introduction to the science and methodology of natural fertility awareness methods, also information on restorative reproductive medicine, but it's not designed to teach you a particular method, and it's not designed to interfere with any medical management. We want to empower you to be an advocate for your own gynecological health, and I hope to inform you about the benefits of appreciating your body and your fertility, and I do not have any relevant financial disclosures. This evening, I will briefly recap what should normally be happening in the female cycle, the woman's cycle, so we can better understand when there are things abnormally happening, how to identify them, and what to do about them. We'll review the importance of 2 foundational aspects of our health as women, which is sleep and decreasing stress. And then we'll dive into the most common women's health issues and how to treat them. We as women can really consider the menstrual cycle as the 5th vital sign. We're probably all very familiar with blood pressure, pulse, respiration, temperature, but the health of our menstrual cycles affects our entire bodies as well. We know this often as women, right? To certain times of our cycle, we might not feel as well as other times. Especially if it's right before the period begins, we might start to feel some of those PMS symptoms creeping in. It can affect our daily life and become debilitating. So Dr. Hillard says this menstrual cycle is a window into the general health and well-being of a woman, not just a reproductive event. It can indicate the status of bone health, heart disease, and ovarian failure, as well as long-term fertility. Therefore, if a woman is not having regular ovulation and menstruation, it's a sign that something else could be going on. So that's really the basis of where we work from at the Gianna Center. So let's review the physiology of the female cycle. We'll highlight the hormonal changes that happen and the resulting physical effects that can be observed. Before we begin, though, let me orient you to the figure here on the page. The left-hand part of the screen is day 1 of the cycle, and the right-hand portion of the cycle is the last day of the cycle. So by convention, the first day of menses is considered day 1 of the cycle. We could also talk about what happens if you have light bleeding or brown bleeding before the period begins. And the day 1 of the cycle marks the beginning of the follicular phase. Early in the follicular phase, hormonal levels are low, and as a result, the cervical fluid is thick and usually does not leave the cervix. Women typically note dryness in the vulval area, indicating infertility. During the follicular phase, the follicular stimulating hormone, or FSH, stimulates the growth and recruitment of ovarian follicles in the ovary. And after in 1 or 2 of the follicles will become dominant in the cycle and proceed towards ovulation. So the developing follicles secrete estradiol, which indicates the growth, which initiates the growth of the endometrium in the lining of the uterus, and also causes glands in the cervix to produce the fertile type of mucus. And next, part 3 of this series, we'll talk about what that would look like. As the estradiol rises before ovulation, the cervical fluid becomes more watery, stretchy, and fertile. Women may note moist or slippery sensation and observe clear, stretchy fluids similar to raw egg white when they're using the bathroom. At first, the increase in estrogen causes a suppression of the LH, which you can see on your screen. But when estrogen reaches a threshold mid-cycle, it causes an LH surge, which results in ovulation. And any woman who is taking ovulation test kits, for instance, would be able to detect their ovulation or their LH rise on that. During ovulation, the follicle ruptures and releases its egg into the fallopian tube. Ovulation usually occurs once per cycle, and fertilization can only occur after the ovum is released and before it dies. So the egg itself is only living 12 to 24 hours. Finally, the second half of the cycle, where that follicle ruptured, becomes what's called the corpus luteum, and it produces progesterone, which sounds like progestation, helping a woman sustain a pregnancy should she become pregnant in that cycle. So when the body recognizes that a woman is not pregnant, then the corpus luteum will atrophy and your new cycle will begin again. The female cycle has 2 distinct phases: the pre-ovulatory or pre-peak phase and the post-ovulatory or the post-peak phase of the cycle. The pre-peak phase is from day 1 of the menses to the day when a woman is ovulating. It correlates with the follicular phase of the cycle and can vary in length. So if there's any variability in a woman's cycle, for instance, it might be 24 days 1 month and 34 days the next month, the variable phase in those cycles would be the time prior to ovulation. Post-ovulatory phase is stable in length with a range of 10 to 17 days long. It's important to understand that ovulation occurs on only 1 day during the course of a given menstrual cycle. Ovulation doesn't occur today and then occur sometime next week. Women also do not ovulate in response to sexual stimulation. These are myths that are not true. This form of double ovulation is an old myth, and we should really dispel it when discussing any natural form of fertility awareness, natural family planning. Ovulation can occur twice or even 3 times in one cycle, as non-identical twins or triplets would prove. But again, a woman would be ovulating 3 follicles within the same 24-hour period. So to repeat, the menstrual cycle begins with the first day of the menstrual bleeding and ends with the last day prior to the beginning of the next period. Most people are aware of the fact that the menstrual cycle might not be regular. However, many people wonder what the difference between a short, a regular, or a long cycle would be. The difference, again, is generally in the length of the pre-ovulatory phase. This would be the variable phase. A short cycle, a woman may be ovulating on day 9 or 10 of her cycle. Regular cycles, she may be ovulating around day 12 to 16, where longer cycles would be beyond 16 days. Just because the cycles vary doesn't mean that they're unhealthy at all. The length of the cycle and each phase varies from woman to woman and even from cycle to cycle in the same woman. Although the average menstrual cycle is 28 days, we now know that only about 10% of all cycles are actually 28 days in length. 21 to 35 day range is considered normal for the whole length of the cycle. And that's why it's important to know the components of fertility which correspond to the phases of the cycle. Tracking your cycles of fertility as a young woman, a young adult, or a woman in her reproductive ages can be used with regular or irregular cycles and ovulation, breastfeeding, premenopause, post pill, or any situation in that you would consider in your cycle. It can be used during your entire procreative life. Many patients who come, we'll talk more about this later in the presentation, who come to the Gianna Center are interested in not using any artificial hormones any longer and would like to transition into using a natural fertility awareness-based method and learning more about their cycle. And we certainly help women to make that change and that transition as easy as possible. Sometimes the cycle can become imbalanced because one of the foundational aspects of health becomes compromised. Two major components of our health, we all know, but sometimes it goes by the wayside, are sleep and stress, especially if we're students. We usually have both of those out balanced most of the time. Signs of chronic stress are a weak immune system, anger, depression, fatigue. It's kind of like we're always in that parasympathetic fight or flight situation. Increased carbohydrate cravings, inability to make decisions, dehydration, heart racing, weight gain, anxiety, brain fog, and just feeling overwhelmed. Even migraines can be a sign of a chronic stress situation. So it's also not normal not to sleep. And I meet many patients at the Gianna Center who will say, yeah, that's how I've always been. I just don't sleep much. And so we really want to try to correct that in a woman for her woman's health, not only for her woman's health, but also for her procreative health. And if you're waking up at 3 or 4 a.m. every night, it's a sign that your body is in a stressful state. The physician, the medical director at the Babylon office, Dr. Paul Carpentier, recommends good sleep hygiene. And what that would be is a cool, dark bedroom, so those blackout curtains, and also wearing socks, because some studies show that that can balance the temperature. Now, it's funny to tell women to wear socks to bed because it can be very hot, but it somehow balances the temperature while you're sleeping. We do, as women, need at least 7 to 9 hours of uninterrupted sleep. It's so important for our women's health. In fact, many of our patients who are in healthcare or shift work, who are working nights and have infertility, they continue to have difficulty achieving a pregnancy until they switch off nights and switch to daytime shift, because it helps your entire body balance and helps ovulation. So Other things that we can do to improve our sleep is to not consume caffeine after noon, 12 o'clock. No screens for 1 hour before bed, to reduce light before bed, to create a bedtime routine, like we had as children, and to calm our body and mind. So, what would that look like? Potentially, doing breathing exercises, stretching exercises. Some patients, I tell them, you can set your alarm for when you think so you can prepare for the next day. What time do I need to go to bed tonight in order to get that amount of sleep the next day? We also want to reduce emotional commotion before bed. And so, anything that's going to cause increased anxiety or things like that before bed, we should reduce that so you can sleep better. Okay. And moving on to the most common GYN conditions. So sometimes in a woman, when sleep is off, or a woman has too much stress, those things alone will create imbalances in her cycle. So we want to, if those things are in good working order and there's still things wrong, we want to make sure that we look at what the root causes of the problems would be. So this is not an exhaustive list of the types of GYN conditions and the services we treat at the Gianna Center, but it gives you an idea of the most common ones. Today, I'm going to go into more depth about the most common conditions we see at the Gianna Center. The first one would be endometriosis. Endometriosis is a condition where endometrial tissue normally found in the uterus is found elsewhere in the pelvic region. It's a frustrating condition that can lead to physical pain, mental and emotional volatility, infertility, and miscarriage. Endometriosis is often underdiagnosed and undertreated as a problem. Many women feel like this is just a part of their cycle that they have to deal with month after month, and not realizing that there is treatment available. It's an estimated that 1 in every 10 women have endometriosis during their reproductive years, and about 1 in 5 teenagers have the disease. It's estimated that it's a condition that affects over 176 million women worldwide. So, endometriosis not only causes pelvic pain, but it negatively affects our fertility as women and can progress, meaning it can get worse over time. And often pain is the only herald of the disease. There's often a significant delay, between 7 to 12 years, in the diagnosis of endometriosis from the time of onset of symptoms suggestive of endometriosis to the gold standard surgical diagnosis. The restorative approach to endometriosis, there are, of course, medications and supplements to reduce inflammation, but the restorative approach to this prevalent disease is not to mask the disease with suppression using artificial hormones or birth control pills, but to destroy it and remove it completely. So you really need to have a good surgeon, a trained surgeon who understands endometriosis to be able to do this surgery. Studies have shown that excision in the expert hands has the potential to eradicate the disease and therefore improve the quality of life of the woman and preserve fertility. We at the Gianna Center see women weekly who often have to miss school and work and their life activities because they have started their period and they're just in a great amount of pain. So I always tell women, you do not have to live like that, and those symptoms can certainly be eradicated. Polycystic ovarian syndrome is another common condition that we treat at the Gianna Center. And I just want to talk a little bit about the difference between PCOS, polycystic ovarian syndrome, and ovarian cysts. Ovarian cysts would be different. An ovarian cyst is a fluid filled sac that develops on the surface or within a woman's ovary. Ovarian cysts are actually very common, and most women will have one at least once in their life. In fact, many women are unaware that they have ovarian cysts because they don't cause any trouble. They cause very little discomfort, and they tend to go away on their own. But if anybody has had an ovarian cyst rupture, now that is very painful, and you usually end up in the ER. Functional ovarian cysts are the most common type of ovarian cysts, and they are related to the normal activities of the ovary, and that is the monthly maturation and bursting of a follicle leading to the release of an egg or ovulation. A follicular cyst can develop if the follicle matures but fails to ovulate. It fails to release an egg. Typically, the remains of the follicle will transform after the release of an egg, becoming what's known as the corpus luteum. But the corpus luteum is responsible for pumping out the progesterone that maintains an early pregnancy should one occur. If that corpus luteum fills with fluid after the egg is released and then closes up again, that's what's called a corpus luteum cyst. Functional cysts are typically not serious, and they tend to go away on their own. However, if a cyst becomes bigger and it doesn't naturally resolve, women often will experience pelvic pain, lower abdominal pain, and bloating. And that's when we have to seek out additional treatment. So PCOS is something different than those two things. Some women's ovaries are prone to developing many cysts, and you can see that on the right-hand portion of the ovary on the diagram there. It can lead to enlargement of the ovaries. And women with these kind of cysts is what's called polycystic ovarian syndrome. And it affects an estimated of 5 to 10% of women of reproductive age. Hallmarks of PCOS are symptoms of cramping and pain around the period, as well as long, irregular cycles. PCOS is also a common cause of infertility. So while the exact cause of PCOS is unknown, they're still doing a lot of research about that, there is really good treatment available for it. Many women suffer from PCOS and they do not know it. And estimates suggest that as many as 75% of women with PCOS are undiagnosed. Because we used to think that PCOS looked a very certain way. A woman would typically have overgrowth of hair, elevated male androgens. They would be overweight, struggle to lose weight, sometimes acne. And now it's more of a syndrome. So women who do not necessarily have all of those symptoms can still have PCOS. So other things that women would present with, again, long or irregular cycles, heavy bleeding during menstruation, cystic acne. So you can have acne not just on the face, but other parts of the body, chronic fatigue, chronic inflammation, cardiovascular issues, diabetes, poor image or eating disorders, hair loss or extra hair growth, of course, the high levels of androgens in the body, and thyroid disorders. But we now know that PCOS symptoms may also include an increased risk of anxiety and depression. Studies have found that depression and anxiety are more prevalent in women with PCOS. The reasons for this are complex, but most of them, they believe, is because PCOS is a difficult condition to live with. It causes undesirable physical side effects and potentially infertility. So one quote from the Restorative Reproductive Medicine online said that it can be deeply stigmatizing to women. And in a quantitative study on subjective experience of PCOS, women describe it as feeling robbed of their self-concept, their essence of being feminine and attractive. So this is something we want to intervene right away if women are dealing with these types of conditions. Premenstrual syndrome, it's only getting better, all these symptoms. Premenstrual symptoms known as PMS are things that we typically, as women, may tend to joke about. and has long been accepted as a fact of life by many women. The chances are, if you're a woman in her reproductive age, that at some point you've experienced an uncomfortable combination of those telltale symptoms warning you that your period's arriving. And if I sat down 10 women at the office and said, how do you know when your period is coming? Each of them would probably come up with a reason that they felt physically or emotionally, not necessarily like because they were tracking their cycles. So symptoms like headaches, mood swings, bloating before the period, but truly it doesn't have to be this way. PMS, or premenstrual syndrome, happens to 13 to 18% of women in the United States. At least 2%, but some studies show up to 9% of women suffer from a more serious form of PMS called PMDD, or premenstrual dysphoric dysfunction, which is so debilitating that women cannot function. It's like a supercharged PMS. It's an estimated that nearly 75% of women experience some form of PMS, with symptoms ranging in severity from mild to seriously disrupting a woman's everyday life. So PMS is definitely real. It can have emotional, behavioral, physical symptoms that women would experience the second half of their cycle. So once a woman can identify ovulation, she would know, I'm in the second half of my cycle, and would be expecting to have PMS symptoms around that time. Symptoms would include bloating, fatigue, acne, breast tenderness. Emotional or behavioral symptoms include sadness, tearfulness, anxiety, moodiness, rage, anger, and changes in the appetite. So sometimes women will have significant cravings, carbohydrate, sugar cravings before the period. So one quote that I found that I really appreciated from Natural Womanhood was a quote by a patient. She said, I didn't understand what was happening. I was afraid to tell my friends and family, which only worsened my anxiety. I was also afraid to discuss these symptoms with my OBGYN because I was afraid he would prescribe me an antidepressant and I didn't want to go on any medication. So a study showed that 45% of women have never discussed PMS symptoms with their doctor, and 24 of the respondents who described their symptoms as strong or severe felt their doctors would not take their complaints seriously. So I see this quite frequently at the Gianna Center, where women feel like I just have to push through it and continue on my daily life when I'm experiencing these symptoms. There are plenty of lifestyle changes that can decrease the severity of PMS symptoms, but more often than not, it's a hormonal issue in the second half of the cycle, which can be corrected. So in standard reproductive health care, we're looking at cycle irregularities. A woman with cycle irregularity or painful periods or heavy bleeding is often put on oral contraceptive birth control pills to regulate her period and lessen the pain and lessen the bleeding. And so what I will usually tell women that it's important as a women's health nurse, and also as a woman myself, I always tell women it's important that you feel like you can live symptom free and that those symptoms would be reduced or eradicated from your cycle. But just like if you had headaches every morning when you woke up and had a headache, you went to the doctor and the doctor said you should continue to take a Tylenol every morning. That Tylenol, of course, would suppress your headache, make the headache go away. But many of us would want further investigation as to why those headaches are occurring. Should we do blood work? Should we do scans? Should we do other testing? Is there something else going on? And as women, we should feel the same way, I think, about our cycles. So if we are having heavy bleeding or cycle irregularity or painful periods, um, instead of taking hormonal birth control or artificial hormones to suppress the cycle, we want to try to find the root cause of why those things are happening. So, although it's a good thing to have the symptoms suppressed, we know that it doesn't address or correct the underlying issue um, of the problem. So that problem would still be there when the artificial hormones are removed. So the problems often return when the patient stops the pill or wants to stop and try to become pregnant. So it's a great time as a young adult to address these issues so you don't have to address them in the future. So, with restorative reproductive medicine, patients are taught how to chart their cycle using one of the methods that are available. We particularly use the Creighton model system at the Gianna Center. And these are evidence based, based on published science, fertility awareness based methods. So, this would help the medical provider identify the pattern of bleeding and determine what the most appropriate cooperative time to the body cycle testing to do are. It will help the physician know if the patient is likely ovulating normally or not. For instance, a woman with a 34-day cycle who bleeds for 5 days, followed by 5 days of brown bleeding, with a normal mucus pattern, and a short time after ovulation to their period, will likely have low progesterone and suboptimal ovulation. These are all things that can be identified um, while doing the charting. Medical therapy can work towards normalizing estrogen and progesterone levels and using other cooperative therapies to minimize recurrence and manage pain or other cycle irregularities in a woman's body. About 65% of our patients at the Gianna Center are come to us because they're struggling with subfertility, infertility, and miscarriage. And they about 40% of those patients have had a diagnosis, which really isn't a diagnosis at all, of unexplained infertility. So at the Gianna Center, we tell our patients that there's 60 to 70 at least diagnoses as to why a woman would not be able to become pregnant. And so the patients, especially those who have unexplained infertility before coming to us, on average, our couples receive 4.5 diagnoses explaining why they are having a delay in conceiving, which is great news, very important for many of our patients. Our patients come to us wanting to have a child or children, but they also want answers. Why is this happening? Um, and so what they found with fertility awareness based methods is that there's that 10 studies have demonstrated the utility of fertility awareness based methods to increase the likelihood of achieving a pregnancy by using cervical mucus monitoring to identify the fertile window. In addition, if a woman is using basal body temperature, the greatest likelihood of pregnancy occurs 1 to 2 days prior to ovulation. By purposefully timing intercourse during high mucus score days, which we would evaluate at the Gianna Center, during the mid-cycle, couples can achieve pregnancy more quickly. So with restorative reproductive medicine and tracking the cycles, couples can achieve a pregnancy more quickly. The International Institute of Restorative Reproductive Medicine believe that every woman who suffers through a miscarriage or early pregnancy loss deserves medical management and intervention to minimize her risks of experiencing another. We disagree with common medical advice to wait until the third loss. So many doctors or OBs would not intervene until a woman has lost or had 3 miscarriages. Often parents affected are told that the loss is genetic, though research suggests that abnormal chromosomes in the embryo may explain only 50% of miscarriages. and tests on the miscarried embryos are rarely performed, so it's a lack of information. Various menstrual or fertility charting indicators have been also associated with the increased risk of miscarriage. So I'll show you a chart after this that just by doing the charting alone would show an increased risk of infertility or miscarriage. Risk factors would include a short luteal phase, brown spotting, low progesterone and or estrogen levels at the peak +7 ovulation phase of the cycle. And so if the hormones are low in the second half of the cycle, they suggest poor luteal phase hormones, likely impaired quality of ovulation, and increased risk of miscarriage. Many doctors, like the ones at the Gianna Center, give natural hormone replacement to bring progesterone and estrogen levels in the luteal phase up to optimal range. They often identify abnormal progesterone levels in pregnancy according to a normal curve that was identified at the Women's Health National Hormone Lab in Omaha. So normalizing reproductive hormones during the luteal phase and during pregnancy will not prevent all miscarriages, of course, but for those women for whom their pregnancy losses are a preventable hormone deficiency, it would reduce the risk of miscarriage. This type of treatment is available at all of our Gianna centers. This charting is an example of a Creighton model system chart. To orient you, day 1 of the cycle is the left-hand part of the screen, and the last day of the cycle is on the right-hand part of the screen. The first line identifies a cycle. Just by doing the cycle charting alone, this person would be at risk of infertility. That's because on day 15, she noticed a particular type of cervical fluid, which she documented on her chart using the vaginal recording system. It's a standardized way to observe and chart. She noticed it only one time through the entire cycle. We know that that is suboptimal, and it's indicating that there's likely a poor ovulation. Even if this woman is ovulating, that's not enough cervical fluid for a woman to be able to achieve a pregnancy. And that's for all the reasons we spoke about last time about why sperm need cervical fluid in order for conception to take place. If you look at the second line, the woman had a 23-day cycle. Her bleeding pattern looks fairly normal. The solid green days are days of dryness. And then from day 12 to day 18 of the cycle, she noticed cervical fluid, and that was her identified time of ovulation. And she identified her peak day using Creighton model system. But remember, the second half of the cycle is only 5 days long. Remember, we want that cycle to be about 12 days long. So her body is starting its process to have a period right when the baby would be implanting in the lining of the uterus about 4 to 6 days after conception. So we have women who come to the Gianna Center with recurrent pregnancy loss. One of our patients had 10 miscarriages in a row and was told she had bad luck from various doctors, that she needed to keep trying, or, in fact, that she would need to go to IVF. And her response was, I don't have any trouble conceiving. How would IVF help me? And that was a very smart thing for her to inquire about. So this particular patient did have a number of things going on with her body, but this is what her chart looked like. So her body, again, right when the baby's implanting, is already weakened because it wasn't prepared to sustain a pregnancy. It was prepared to start a new cycle. So this particular patient, we said, do not try to achieve a pregnancy Right now, we want to correct what we need to correct. And once we did that, then they had intercourse during the fertile time. They were able to achieve a pregnancy. And with the correct treatment and support, she was able to go on and have a healthy 40-week pregnancy, a little girl. And actually now she's pregnant with her second baby with us. So we're really overjoyed with those results. Unfortunately, somebody like this patient would probably continue to miscarry without the correct interventions. And these are things that can be avoided. And so we want to be able to educate women and treat that when we see that happening. We are very familiar that the most common treatment for most women's health issues would be hormonal birth control. And there are many side effects to that. And so, with restorative reproductive medicine, our goal is truly to find the underlying cause of all of the reproductive issues that a woman would have, and correct them so that there would not be any need to use artificial hormones for medical treatment. So, one study that I always particularly point to, especially for college students and young adults, is that a study of over 1 million females ages 15 to 35 who were followed for nearly 6 years who used hormonal birth control were 2 times more likely to be prescribed antidepressants because we know that it affects a woman emotionally and mentally. And are there other options? Are there healthier options that we could potentially look into? With restorative reproductive medicine, we do not have a need for hormonal suppression of a cycle. We really correct it and treat it. We do use hormones and, of course, medications, but we use them timed to the cycle so that the cycle is not suppressed and the cycle is not overstimulated. So it's working cooperatively with the body. Reproductive medicine has really evolved into 2 very divergent streams in the last several decades. And most people, like we were talking about, are aware of the standard version, but these treatments don't aim necessarily to correct or restore underlying function, but to use the medications to suppress the cycle or circumvent or destroy normal reproductive functions. Restorative reproductive medicine uses the approach that only restores or optimizes reproductive function. It's a standard medical approach, medical model, meaning you have to diagnose and understand the problem before you can treat it. The tests, medications, and surgery used in restorative reproductive medicine are similar to standard reproductive medicine, except they are used in such a way as to normalize and restore function or optimize if restoration is not possible. To know what is normal and what is not, most women with cycles are taught fertility awareness-based methods so they can identify what's normal and not. And I always like to point out this slide is courtesy of facts and how hormonal birth control works to suppress a cycle. So the first thing it does is inhibit ovulation, and it does that pretty successfully. The second backup mechanism is to thicken cervical mucus. The third would be to delay the ovum sperm transport, so delay conception, which would take place within the fallopian tube. And the fourth would be to inhibit implantation. It really makes the lining of the uterus inhospitable to implantation. Now, you may know people who've conceived or had a baby while taking hormonal contraceptives. I've taken care of patients in this particular category, postpartum on the hospital floor. And what's important to know is that a woman, of course, can have breakthrough ovulation. And if all those backup modalities fail, then a woman could conceive. But the fourth one, inhibit implantation. I always want to highlight that because if you do have a breakthrough ovulation and conception takes place within the fallopian tube, it's even less likely that the baby would be able to implant in the lining of the uterus. Many women are not aware of these modalities of how birth control treatments actually work. Um, so again, we avoid them at the Gianna Center. We don't have a need for them for procreative health or for restoring reproductive health. So again, restorative reproductive medicine is offered at the Gianna Center, and it's a medical approach that looks to restore a woman's cycle, and it works cooperatively with the woman's cycle. So we don't want to suppress the cycle or overstimulate the cycle. There are a number of resources for really women of all ages, especially young adults. And if you're a particularly science minded person, I encourage you to look at FACTS and the International Institute for Restorative Reproductive Medicine to look at the research that is currently being done, the ones that have been done, not only in our country but around the world, and it's absolutely fascinating. And the women really have a demand. There's a demand for it because women desire it. And then also, natural womanhood is a great resource for women who are interested in fertility awareness-based methods and more of a natural approach to healing their own bodies. And finally, at the Gianna Center, we are proudly a part of Catholic Health Services, Catholic Health Now, and the Gianna centers that are located underneath the umbrella of Catholic Health are Manhattan, Rockville Center, and Long Island. And the physician names and nurse practitioner names are located on your screens, and also the telephone numbers. So we do accept most major health insurances, both for women's health visits and for fertility care charting classes. And there are also telehealth visits that are available during this time. So thank you very much for your time this evening, and I would be happy to take any questions that you might have that you'd like to ask. You can put them in the chat, or if somebody would like to unmute, you can certainly ask a question then too.
I have a few questions, but I don't know if we should stop the recording before, or it doesn't matter.